Marcelo, pode iniciar.
Bom dia a todos e todas. Nós estamos iniciando essa atividade do Centro de Estudos do Instituto de Psiquiatria da UFRJ, hoje, 14 de junho de 2024. Temos a honra de receber a professora Linda Clare, que é professora da Universidade de Exeter, no Reino Unido, que vai dar uma importante conferência sobre demência, né, e qualidade de vida. Eu vou passar agora a apresentação, eu vou falar agora em inglês e vou passar em seguida para a professora Márcia Dourado, que vai complementar a apresentação da professora Linda Clare. Hello everybody. We have the honor to have Professor Linda Clare with us. Professor Linda Clare is professor of the University of Exeter in United Kingdom, and she will present a lecture about dementia. And it's very important for us in Instituto de Psiquiatria da UFRJ and in Brazil to have this conversation with Professor Linda Clare. So now I will pass the word to Professor Márcia Dourado, who will finish the presentation of Professor Linda Clare.
Bom dia a todos e a todas. É uma honra nós podermos receber hoje a professora Linda Clare. Eu falo em nome do Programa de Pós-Graduação em Psiquiatria e Saúde Mental, do qual eu sou a coordenadora. Esse evento é uma iniciativa do Grupo de Trabalho de Internacionalização do PROPSAM, e ele tem como objetivo nós podermos trocar conhecimento, abrir colaborações e termos uma melhor visão, de que maneira a ciência se desenvolve ao redor do mundo e como é que nós, aqui no Brasil e principalmente aqui dentro do PROPSAM, podemos nos aliar a esse desenvolvimento. A professora Linda Clare, ela é professora de Psicologia Clínica em Envelhecimento e Demência. Ela é diretora do Centro de Pesquisas em Envelhecimento e Saúde Cognitiva da Universidade de Exeter. E ela lidera a Unidade de Pesquisa de Políticas em Demência e Neurodegeneração do Instituto Nacional para a Saúde e Cuidados, do Reino Unido. Então, good morning. It's an honor to have you here, Professor Linda Clare. Now I'm speaking as the coordinator of the post-graduation program of psychiatry and mental health. And this event is an initiative, is an active of our internationalization working group. And it's an interactive scientific meeting with the objective to share collaborations between PROPSAM and international researchers. And your lecture is a great collaboration for us. And Professor Linda Clare is a professor of Clinical Psychology and Age and Dementia at the University of Exeter, Director of the Aging and Cognitive Health Research Center, and she leads the Policy Research Unit on Dementia and Neurodegeneration of the National Institute of Health and Care Research. She is also part of the world's best psychology scientists list, and so it's a very, we are very honored to have you here. So you can go.
Thank you, Marcia. Can you hear me all right now?
Yes.
You can, good. Thank you very much. It's a great honor to be talking to you today. And I'm going to talk about a 10-year research program called Improving the Experience of Dementia and Enhancing Active Life, which we shorten to IDEAL, the IDEAL program. And this is really looking at quality of life for people with mild to moderate dementia and their family members. So that's what I'm going to focus on today. I just want to start by acknowledging our funders and to say that the original funding for this programme was part of a UK government commitment to supporting social science research in dementia, and that was linked to the G8 summit held in London in 2013. I also want to express my thanks to a group of people with dementia and their family carers who have been involved in the programme. We always try to involve people with dementia and carers in our work, and we have this involvement group who have been with us, most of them throughout the programme. Some have had to leave as their dementia progressed, others joined. But they have taught us a lot about involvement, and through their work we've progressed from just asking advice and getting them to comment on things to a real co-production and partnership approach. And I think we've also learned a lot from the kindness and care they show for each other and for the research team. That's benefited the whole programme. And this programme started in 2014 and will finish at the end of this year. So it's a good time to be telling you about, I've got a good overview now of the findings. It's a good time to be telling you about that work. So what were the aims of the IDEAL research programme? This programme had its origins really in the UK's first dementia strategy, which was produced in 2009. And the strategy, at that time, of course, there was very little available in the way of drug treatments and so forth for people with dementia. And the strategy focused very much on living well. How could people live well with dementia in the community? Now, people with dementia don't always like this term living well. As far as they're concerned, they're living with the condition. But it is a useful term because it's an aspirational term. It helps us to think about what could be achieved to enable people with dementia to have a good quality of life, or how we could improve or help to maintain a quality of life for people who have dementia and for their family members. And what we heard from people with dementia is that when they get diagnosed, they may be given some information. But one thing they're not given is hope for how they can live with the condition. And of course, people often live with dementia for many years, especially with increasing emphasis on early diagnosis. So we wanted to understand what are the key influences on quality of life for people with dementia and carers. How do they affect each other in terms of quality of life? And what role do formal services play? What helps people to continue living well over time, or to continue having a good quality of life over time? And what might alert us to the fact that someone is at risk of declining in quality of life? For example, if someone comes to our clinic or our centre or our service, what might make us think that they are at risk of getting into difficulty, and what could we do at that point to try to prevent that? We wanted to understand how social inequalities and diversity affects ability to experience a good quality of life. And we wanted to understand more about how to measure and monitor quality of life or living well with dementia. And we wanted to also to translate our knowledge into practical resources that could directly benefit people living with dementia and carers, practical resources for people who plan and provide services like service commissioners and practitioners, and for the general public to increase public awareness and understanding, which is really vital. And I'll tell you about some of the resources we developed as I go through their talk. And one thing we included in IDEAL was arts-based approaches, because these are a great way of stimulating debate, increasing awareness of issues, and so forth. So I will show you some of those as well. And the first one, I'll just start now with the first of those, which was called the Unfurlings. And we, I don't know if you have this tradition in Brazil, but in this country, there's a tradition of trade unions, and they would have a big banner describing who they are and a logo or illustration, and they would march proudly through the streets demonstrating their views. And in that tradition, our artists who work with us on this project linked up with groups of people living with dementia and made a series of banners. They called them Banners for Hope and Change. And these banners put forward some of the experiences of living with dementia and the views of the people with dementia who made them. And I'll show you some of these as we go through the talk, and you'll see how they relate to the research. So I'll start by giving you an overview of the research programme. As I said, it was a 10-year programme focused on people with mild to moderate dementia living in their own homes in the community. We recruited a cohort of people with dementia through National Health Service sites. These were providing services for people with dementia, so there might be memory clinics where people were diagnosed. And we recruited over 1,700 people with dementia in 34 areas of the UK. And over 1,400 had a family carer also participating. We didn't say they had to have a carer. They could be living on their own and they might not have a family member involved, or indeed they might not have a family member supporting them. And we didn't mind what kind of dementia they had. They just had to have a diagnosis of dementia. And we followed up as many of them as possible over 6 waves of interviews. And those were meant to be at yearly intervals. And we gave lots of questionnaires. We also had additional in-depth interviews with a smaller number of people. And as the programme progressed, we had some linked studies with what could be called underrepresented groups. And so they weren't necessarily underrepresented. They're groups where numbers are small at the moment, but will increase in time. So people from Black and minority ethnic communities, for example. We also looked at people who were living with what appeared to be undiagnosed dementia in collaboration with another study, CFAS Wales. And we have thought a bit about people with more severe dementia as well, although our main focus was people with mild to moderate dementia. So this was how we set the programme out. Our first set of funding covered 3 waves of assessment, each a year apart. And we had some of those other activities going on as well, including an international meeting, which Marcia was able to come to. We then had a 2-year gap because our funding changed. We had a second round of funding, and we planned another 3 waves of assessment at yearly intervals. Timing was unfortunate. The COVID pandemic intervened. So we moved our data collection online, and we were still able to do some COVID-related work and to collect further IDEAL programme data. But it did mean that our numbers were smaller in these later time points. And we had those other activities that I had mentioned as well. So central to this whole programme was this big cohort study. And We did work across the UK. The way we were able to do this was that our National Institute of Health and Care Research has a clinical research network of staff who are employed to recruit people into research studies and can also do visits to them to gather information. So we had a large number of researchers out there supporting IDEAL. I calculated that we had 56 local principal investigators and 273 researchers who collected data in these early stages. Once we moved online due to COVID, we did that centrally from our own team. So this is just a bit of a summary of the cohort. These are the people living with dementia. Slightly more men than women, but not hugely more. And the age distribution is pretty much what you would expect for a cohort of people with dementia, the larger group being over 80. But we did have a good number of people with young onset dementia as well, which is helpful too, because we can then think about their particular needs. In terms of diagnosis, the distribution was very much what we expected based on existing UK data. Alzheimer's disease counting for about half of the diagnoses, and then mixed Alzheimer's and vascular disease and vascular dementia. And then we had these other rarer dementias represented in the proportions that we would have roughly anticipated. There was a fair amount of diversity in the cohort, but it was limited in some respects. I already mentioned ethnicity. We did not have a large number of people from minority ethnic groups, but based on what we knew about UK existing data, we thought this was a reasonable snapshot of people who had attended memory services and been diagnosed with dementia. As I said, we included family carers. These, again, as we would expect, were more likely to be female than male. They were also largely an older group, although younger in profile than the people with dementia, because some were adult children, but 4 out of 5 were spouses or partners. So that was our cohort. Of course, being good researchers, we started with a systematic review of existing evidence. And we were rather surprised, in fact, to find that it didn't tell us a great deal. It showed that a lot of things have small links with living well or quality of life when they're measured at the same time. The few that stood out were good relationships, social engagement, and better functional ability, which were linked to better quality of life, while poor mental and physical health and poor well-being in the carer were linked to poorer quality of life. But beyond that, it didn't give us any real pointers. In particular, there was very little longitudinal evidence to say what might signal that someone was at risk of decline in quality of life. So we didn't have a good overall picture. We were lucky to have not only our involvement group of people with dementia called the Always Group, but an advisory group, an independent advisory group, who advised us to start by focusing on the whole picture and how everything links together to shape whether someone is living well. So we did start by doing that, both for people with dementia and carers, before we went into detail about specific issues. So I'll explain the process we went through first for the people with dementia. We had this concept of living well, which I've likened now to quality of life. We had a lot of discussions about this concept and how to measure it in the early days, because of course there are no questionnaires of living well. But there's a very nice definition prepared by the Institute of Medicine, which talks about well-being, satisfaction with life, and so forth. And we drew on that quite heavily. And we also drew on the World Health Organization model with its focus on functioning, because we wanted to have a broad look at how people were doing and not just think about managing symptoms. And we know that there's a range of things that affect well-being and inclusion, the context and the environment, for example. dementia poses challenges because symptoms make things harder, but these wider contextual factors have a huge impact. And they might be because the person loses anxiety, has anxiety or loses confidence. It might be because other people react in a negative way. It might be because environments are not well adapted to support someone with cognitive impairment, or because communities are not inclusive. So we thought about living well as a balance between those kinds of challenges and the resources that you have. And resources could include things like a positive outlook, good social networks and friendships, having enough money, being physically fit, and so on. So that's how we thought about what we wanted to look at. And we decided to evaluate living well in terms of quality of life, well-being, and feelings of satisfaction with life. And so we used questionnaire measures of those three things: the quality of life in Alzheimer's disease scale, the World Health Organization 5 Wellbeing Scale, and the Satisfaction with Life scale. We also had an open question about what does living well mean to you? And we had in-depth interviews with a subset of our participants, as I mentioned before. And alongside those measures, we looked at the resources that people had in several life domains: physical health, psychological health, their social resources and their social situation, and how they were managing their everyday life. We looked at how the person and carer affected each other. And as I've said, we wanted to look at changes over time. So the advice to look at the big picture rather than taking individual variables and seeing whether they related to any of our measures of living well was very good advice, but it was a challenge for our statistical experts. However, they rose to the challenge, and this is what they came up with. So this was our living well model, influences on living well for people with dementia. So remember, living well is quality of life, well-being, and satisfaction with life. This is a quite complex statistical model. It shows how the various domains of life that we investigated are linked to being able to live well when everything is measured at the same time. Perhaps a more straightforward way of looking at it is to graph it like this. So these are domains, various measures grouped under these broad domains: psychological characteristics, social situation, physical health, social resources, and everyday activity. And the orange bars show how each domain is linked to living well when we look at them separately. So you can see that all of those domains in which we group the relevant variables are linked to living well. When we model them all together, that's the blue bars, it's the psychological domain that comes out as most important. It doesn't mean the other aspects are not important, but how we interpret this is that all of these aspects of life affect psychological well-being, and that in turn is very closely related to whether you think you are living well. So psychological well-being is key here, and all of the things that influence psychological well-being are going to be important. So having seen this picture of the many things influencing quality of life, we also wanted to look at how living well, capability to live well, or quality of life changes over time. And so here I'm showing the quality of life score mapped against years since diagnosis for people in our cohort. There's another challenge for our statistical experts, because over time, among those people who stay in the cohort, when we look at them as a group and took the average, there didn't seem to be much change. You can see that quality of life declines a little bit more for men than women, but there's very little difference. And actually, the overall score is quite high. Now, of course, that doesn't account for people that may have left the cohort, as we did have of people withdrawing over time, not surprisingly in a study of people with dementia. But for those who stayed, quality of life looked relatively stable at group level. But there was a lot of individual variation, and so we were able to see what signals the risk of a decline in quality of life. And what we found was, again, psychological health comes out as very important. So if we see at one time point that someone is starting to show a decline and measures of psychological health, this increases the risk of a significant drop in quality of life scores a year later. So if someone is depressed, is experiencing low self-esteem, is saying that they feel they're not the same person as before, and feeling lonely, these things all suggest that there's going to be a decline in quality of life later on. So to prevent that happening, we need to be supporting people's psychological well-being. And as we've seen, that rests on the person doing well across those other domains that are also important. And we started thinking about this kind of like a map, all of the things that are kind of a scheme of how this might work. And so we started putting it together in that way. So these are our domains. And I've just added some of the quotes that people gave us when they talked about what living well or quality of life meant to them. So for psychological characteristics and health, not being despondent, being useful, keeping motivated. Having friends was important, social resources, having good health. And for everyday activities, balancing what I want to do and what I can do. So all of these things are important for living well. And then, of course, we know what we need to do to prevent a decline in quality of life or to help people maintain their quality of life. So this was our initial Living Well map, as we called it, or Living with Dementia map. And then we worked on filling out the details. So we went into more detail about individual variables in each of these domains, as well as some other possibly important influences. So what I'm going to do now is just give some examples of things within the different domains that affect quality of life or living well. Physical health, of course, very important. Many of our sample had other health conditions as well as dementia. The majority here having one or two other illnesses. And on the right, you can see the mean score for quality of life plotted against the number of other health conditions. And as the number of health conditions increases, quality of life declines. For managing everyday life, we looked at functional ability. This is the functional ability questionnaire. And again, this is what this is showing is different levels of scoring from high to low on the functional ability scale. So a lower score is better on this scale. And so these are now standardized scores mapped against quality of life, satisfaction with life and well-being. And you can see that all of those indicators decline as the functional ability also declines. So functional ability to manage your everyday activities, to do things, to stay involved in enjoyable pursuits and so forth is also very important. And of course, everyday life when you have dementia is fraught with challenges as society becomes more technologically complex. And this is an example from the Furlings, the Banners study of a group who had become very concerned about automated cash machines. I don't know if you have a lot of these, but in this country, bank branches are closing down all over the place and people have to rely on these machines to get their money out. And for people with dementia, this can be very difficult. So this particular group wanted to raise awareness of the need to make everyday technology, the technology we encounter in everyday life, such as these automated teller machines, accessible and user-friendly. Another group focused on public transport, again, challenging to be able to navigate timetables, purchasing tickets, getting on the right train at the right time, and so forth. And so this group made a banner about the right to being in their area. They call it a grand day out, a day trip to the seaside or a visit somewhere interesting. And they portrayed the difficulties and then the benefits of having a good day out. And they held a public awareness event on a railway station to publicise their views on this topic, which was attended by press and had accompanied by a brass band, also a feature of their particular area of the country. So this was translating some of those findings into practical things that could be done, practical improvements that could be made to include people with dementia more in their communities. So moving on to psychological health, loneliness is a big challenge for older people in general in this country. Well, for everyone, but especially older people in this country. I don't know how that is in Brazil, but many older people here experience a great deal of loneliness and have few social contacts. And that could be even more the case for people living with dementia. So we looked at prevalence of loneliness. Actually, it was fairly similar to the general older population. So about a third were moderately or severely lonely. And then we looked at, this time it's the well-being score, WHO-5 well-being score, and plotted that by degree of loneliness. And as loneliness increases, again, you can see well-being decreases. And this group, this was a local group in Exeter run by an organisation called Age UK, a charity, wanted to raise awareness of the importance of friendship and tackling loneliness. They had a gardening group called Budding Friends, where people with dementia and carers came together and in the summer did gardening on an allotment, and in the winter would do indoor activities. And they wanted to emphasise the importance and the value of friendship and how that could help transform someone's life. So these small organisations are very vital, small community groups are vital in providing that sort of social network, although they find it very hard to keep going because of having to constantly apply for funding. Also on the psychological domain, understanding and adjusting to dementia, people do this in different ways. So we developed a measure of this, and we studied with our cohort how they were making sense of dementia. And so the largest group here, 45%, what we term the disease symptoms group, they think about dementia as an illness or disease, but they don't talk about it using the term dementia or Alzheimer's. They talk about memory problems or memory loss or forgetfulness or similar things. And we saw there were several other groups, some who do use those more medical terms, who think about dementia as an illness and use diagnostic terms to describe it. So we called them the disease diagnosis group. And then we have people who see their difficulties as an expected aspect of aging. You expect to have poor memory when you get older. We have also a group who say there's no problem. They don't acknowledge any dementia-related difficulties, although other people see that there are difficulties, that they are having difficulties. And interestingly, the large group who really didn't have any clear idea of how to make sense of what was happening to them, despite any information they might have been given, they weren't able to kind of articulate a clear understanding at all. Nearly a quarter. So what we found was that the people who thought about dementia as part of getting older had better quality of life, well-being and satisfaction with life than those who thought about dementia as a disease and used medical words to talk about it. And this is very interesting because, of course, we want to inform people, and we're always aiming to inform people about the condition and educate them about the condition. But in fact, thinking about it that way does have a bit of a cost in terms of how people feel about themselves and their situation. And I just wanted to pick up on the no problem group, very interesting group. And as Marcia, I know, has an interest in this area as well, I'll just briefly comment on this. So this no problem group might be thought about as people who lack awareness that they have dementia or that they have particular symptoms or difficulties. It's quite a small group. So lack of awareness is not pervasive in any way for people, among people with dementia. They're a small group. My then PhD student, Kathy Alexander, looked at this and looked at this group of people who might be considered to have low awareness, the no problem group. And at time 1, there were 83 of them. And she looked at what happened to those who stayed in the cohort. And at time 2, a year later, there were fewer. Some still had low awareness, saying there was no problem, and others had some awareness. They were showing awareness. And then at time 3, some of those who had maintained low awareness at time 2 were showing awareness, as were some of those who showed awareness, did show awareness at time 2. Some of those who showed awareness at time 2, however, appeared to show low awareness again at time 3, and some continued to show low awareness. So there were very few who showed low awareness all the way through. So, I think it's really important that we shouldn't be thinking of low awareness as fixed and unchangeable or as a fixed symptom of dementia. And it's likely that there are different underlying reasons why people show low awareness. And sometimes that could be neurological and it's not going to change, but other times might well be psychosocial, might be about adjusting to the condition. It might be about, might be a sense of denial or taking time to adjust or accept what was happening. Or even it could be about saving face and stigma. And it could be about how we interview people and elicit that information, that, different people at different times might elicit different responses. So another one of our arts-based project was around adjusting to the onset of and diagnosis of dementia. And this was an opera, a one-act opera that we commissioned. We worked with a director and a composer to develop, perform and film this opera, the idea being to promote public understanding and reduce stigma. So it portrayed a couple where the husband developed and was diagnosed with dementia and the journey they went on and how they influenced each other's reactions. And we looked at we looked in our study at how carers' experiences were linked to living well for the person with dementia. And we knew that, for example, where carers were more stressed, the person with dementia had lower well-being. So we went into a bit more detail about this using actor-partner independence analysis methods. This was a relatively new statistical method, looking at how the experience of each person in that couple, where there was a couple, did or did not affect the other's well-being. So for the person with dementia, depression, loneliness, isolation, I'll start again. For the person with dementia, all of these things, depression, loneliness, isolation, and poor quality relationship with the carer affected their own well-being, quality of life, and satisfaction with life. And similarly for the carer, all of those things affected their own capability to live well with the condition. So for the person with dementia, if the person was depressed and lonely, that also affected the carer's capability to live well. But isolation and poor quality relationship didn't. And for the carer, if the carer was depressed or felt isolated, that affected how the person with dementia was doing. But if the carer being lonely or perceiving the quality of relationship poorly didn't seem to affect that. So quite an interesting and nuanced set of interactions there between the person and the carer. And just highlighting again that we need to focus, where there are these close relationships, we do need to focus on how people are doing as a couple and on communication in those situations. And that really stimulated another arts-based output, which was called The World Turned Upside Down. It was a documentary, a play originally, that was performed 3 times, where actors improvised scenarios and then the audience was invited to comment and they would try them a different way to see if it would improve communication. And we made a documentary film about this, which you can find on YouTube or via this link. The play itself was performed 3 times and there's been a number of public screenings of the film, but it's available on YouTube to watch. So all of this putting together gave us, this filled out our living with dementia map. So now in each of those domains, we could say which of those things, positive or negative, affected living well. So for example, let's take managing life with dementia. So we saw that being able to manage daily activities better was a positive effect, and having difficult symptoms such as hallucinations interfering with that was a negative effect. And that influenced living well through these psychological characteristics. Similarly, social resources, in being active in doing social activities, feeling positive about the neighborhood you live in, were good influences, and being socially isolated and a negative influence on psychological characteristics and health, and then through that on living well. So we're able to fill out some of those things that make a difference in how well people are doing. And of course, we already knew, we had talked before about the factors that link with, that are risk factors for decline. And we went on to develop this into a resource for professionals and practitioners. So what we tried to do here, this may be a little difficult to see, but what we tried to do was to suggest the things that practitioners should be asking about, or could be asking about, when they talk to people living with dementia. And also to back that up, on that we can't see here, but also on the back would be some of the evidence, the explanations of the evidence from the programme. And this is also relevant for the people in our system. There are commissioners of services in the National Health Service who decide what services will be offered. So it's also relevant for them to think about what should services be covering. And we also created then a questionnaire. We noticed that there was many questionnaires address quality of life, well-being and so forth, but not necessarily involving the views of people with dementia as to what would make a useful questionnaire that they would find accessible to complete. So we, having our Living Well map and those domains and the answers to our open-ended question, what does living well mean to you, which over 1,300 people responded to, we generated possible questionnaire items and went through a whole co-production process with a group of people living with dementia to develop the questionnaire, and we tested the items, refined them down to a small set, and validated this questionnaire to show that it was a robust measure of living well. It correlates well with quality of life, well-being and satisfaction with life measures, but is also accessible. And the co-production group wanted to create a questionnaire that they themselves would like to fill in, and so they worked with us on the design as well. And so it's a 10-item questionnaire, easy to complete, and covers very nicely those domains in the Living Well map. So now being used by some practitioners in the UK. I'm just going to talk a little bit about carers, because when we think about who's providing care, and again, I don't know how this looks in Brazil, but in the UK, for people with mild to moderate dementia, the vast majority of care is provided by unpaid carers, relatively little by paid services. And both of those proportions increase over time, but the amount of unpaid care increases more dramatically. So the costs primarily of care are costs of unpaid informal care in the community to family members. And it's very important to think about carer well-being to sustain this. So one of our groups of carers wanted to make a banner showing that they're here and they care. And we did work with our Alzheimer's Society on a policy report about this, about reinforcing support for carers as well. And we had a similar Living Well model for carers. I won't dwell on this now, but it also led to a similar Living Well map with the same domains, but also with the addition of the experience of caregiving, because we know that the restrictions and the stress resulting from caregiving, the feelings of role captivity, can have a damaging effect, but also that there are positive benefits for some carers too, which is important to understand. and we produced a carers version of the Living with Dementia map to enable professionals and practitioners to make sure they cover all of those important areas. That's a parallel resource. So both for carers and for people with dementia who are trying to navigate health and social care services, so formal services, can feel like a confusing and frustrating maze, as this group wanted to illustrate. And we looked at what services people had received, what health and care services they'd received. And we found that in general, they received little support. And we also found evidence of inequalities. For example, older women were less likely than others to receive services and support. And that evidence contributed to another Alzheimer's Society policy report. And thinking about inequalities has been very important in IDEAL, and I will focus a little bit on diversity and pick up a few angles here. So first of all, I showed you earlier, and you'll remember that overall quality of life scores didn't change much over time and were quite good, quite high on the scale with the maximum score there. But when we look by diagnosis, we see that this does vary. So people with Alzheimer's disease have the highest scores. Right down at the bottom are people who have Parkinson's disease dementia or Lewy body dementia. So, you know, we tend to think and talk about dementia as one thing, but this is misleading, and we should perhaps be thinking and talking more specifically about different diagnostic groups. And we think for people with Parkinsonian dementias, obviously there's been other disabilities, extra motor related symptoms or other symptoms, and for people with Parkinson's disease dementia, a longer period of disability predating the development of dementia, which may be why they seem to be doing less well. Social disadvantage. So we looked here at area level deprivation. So here we have plotted area level deprivation from the least to most in quintiles. So against that, we've plotted mean quality of life scores. So people in the most deprived areas having, as you see, as area level deprivation increases, quality of life decreases. So social disadvantage is linked to living well. What about living alone rather than living with others? So we had about 18% of our cohort living alone. And we think that is roughly about the number of people with mild to moderate, about the proportion of people with mild to moderate dementia living alone. It varies in different studies, but it's possibly about 1 in 5 or maybe even more. So more female than male, and tending to be older, aged over 80, sometimes living alone for different reasons, sometimes widowed, bereaved, other time, and some obviously have been living alone previously and are used to it. So it does vary as to why people are living alone. But overall, if we compare with those living with others, people living alone tend to have better scores for cognition and functional ability, possibly because they have to. These are the people that are better able to manage everyday activities, and they have more social contact outside the home. They're also more likely to pay for in-home care and use assistive technology. But they're more prone to depression and more likely to feel lonely, and they're experiencing lower quality of life, satisfaction with life, and well-being. And over time, those differences stay the same between people living alone and people living with others. But of course, people living alone, and that relates to this first point about better ability, people living alone are more likely to have to move into a care home when it becomes difficult to manage. Another aspect we looked at was in the UK was our Black and South Asian communities. These are some of our important minority ethnic groups. And we found, compared to matched white British groups, people of Indian, Pakistani, Bangladeshi, African or Caribbean origin, people with dementia had poorer quality of life and higher loneliness, and their carers were more stressed, felt more captive in their role, and felt the relationship with the person with dementia was poorer. Why is this? Well, there was in the qualitative interviews evidence about being a migrant. So some of these would be first generation, and that would transmit to second generation. So there were feelings of not belonging, there were experiences of discrimination and experiences of racism. And then there's a sort of cultural context, because in many of these communities, dementia is viewed differently, but the prevailing services are often not equipped to deal with that, or not really understanding it. So there are issues around knowledge and attitudes and access to services and appropriate, culturally appropriate service provision as well. So one of our group that made a banner simply asked, "When we talk, will you listen?" This was a group of South Asian people with dementia. And they were concerned in particular about losing skills in English, which was their second language, as their dementia progressed. So I think focusing on diversity does remind us about the importance and relevance of a personalised understanding of each individual. We have looked at various aspects of inequality and disadvantage individually, but we also wanted to think about how these things go together, because very often people are not just suffering one type of disadvantage, there are multiple sources of disadvantage. So this is recent work, still really in progress. We use data about personal characteristics, living situation, socioeconomic position and geographical area, and how that interacted with our quality of life measure. And we use decision tree analyses to look at the intersection of factors beyond type of dementia and comorbidity, and how that allows us to identify subgroups of people with dementia experiencing higher or lower capability for living well. So we found that age, education, living situation, income, and home ownership were the strongest differentiators. So in this decision tree, it's grouping people first by home ownership, those who do and don't own their own home. That's a really important economic indicator in British society. Home ownership is something people aspire to very strongly. So for those who do own their own home, it further divides them by income, lowest to highest, and among the highest, it divides them by whether they do or do not use the internet. And you can see that quality of life scores go from lower to higher across those groups. If we go to the people who don't own their own home, it further divides them by age, younger, under 65 and older, and among the over 65s, again by education, whether they have educational qualifications or not. And we can see again quality of life scores going from lower to higher among those groups. And actually the people with the home ownership, higher income and higher income are doing better than all of those groups. So these findings help to shed light on how combinations of factors contribute to inequalities in capability to live well or experience good quality of life with mild to moderate dementia. So I guess these findings from a cohort of people living with dementia in a major Western economy represent the tip of the iceberg relative to the full extent of national, but especially global inequalities. So that really does require a sustained focus on developing and implementing policies that improve equity of access to care and support and increase potential to experience a good quality of life. Now, I've included a section on the COVID pandemic. For reasons of time, I'm going to skip through that. I guess you'll have access to these slides anyway afterwards. I'm just going to move through that. But just to say, the COVID pandemic did really get us to get our skates on about providing evidence-based information and advice, and we produced information leaflets which were translated into 10 more languages by the UK Race Equality Foundation. But building on that, we This evolved into one of our most important outputs, the Living with Dementia Toolkit. It's an online toolkit for people living with dementia, also looked at, of course, by carers and indeed practitioners. It's online. There were printed guides in English and Welsh, Welsh being our second, one of our 4 constituent nations, having Wales as a bilingual English-Welsh nation, and so Welsh was important there. So the Living with Dementia Toolkit covers all those domains in our Living with Dementia map and provides information and resources for people to inspire them. It was co-produced by people living with dementia and carers. And it, as I said, offers resources to provide ideas, inspiration and hope. It's included in the World Health Organization Global Dementia Observatory Knowledge Exchange Forum, and it's been accessed so far by an amazing number of users, 123,000 people from 130 countries. And we know that in the UK, these materials are being used by individuals, by doctors, by memory clinics and mental health teams, as well as community and voluntary sector groups. Co-production was really interesting because there were topics where people with dementia and carers might differ, typically. For example, risk, where carers tend to be risk averse and people with dementia are often keen to take a few risks and make the most of their lives. And I think by having that co-production with both perspectives together, we were able to come to a good consensus. The toolkit also includes some discrete resources, such as My Life, My Goals. That was developed, again, co-produced with people with dementia, which supports people making everyday life more manageable. And again, it's something people can use themselves or with a family member, but it's also being used by practitioners. And then My Life Today, another co-produced resource aimed at helping people think about what helps them to have a good quality of life and to track whether those things are actually happening and make any changes needed to ensure that they are present in their lives. So we're testing that at the moment. And just one last resource I'll share with you, a slightly unusual one for a research project. We have our own song. It was we commissioned the song. It was written and performed by musicians who have dementia in Liverpool in the UK. Here they are. And it was adopted as the official song of the Alzheimer's Disease International Conference in London in 2022. And again, was designed to give a message of hope and togetherness. And we are still working on our last major output, which will be a book. There's a Reconsidering Dementia series published by the Open University Press in the UK. This takes the seminal work of Tom Kitwood, such as his book on dementia that came out in the late 1990s, Dementia Reconsidered. And our volume will give an accessible account of the ideal evidence on quality of life or living well. And we've co-produced this book as well with our Always group, our involvement group of people with dementia and carers, as a manifesto and a call to action to improve the potential for people living with dementia to have a good quality of life in the community. We think this will come out in sometime in 2025. I don't have a more exact date yet. And we're just drawing this program to a close. It will finish at the end of this year. We've got some more analyses to do. But in the meantime, we have been able to put our experience in the program to good use, and we secured funding to become a National Institute for Health and Care Research policy research unit, which means that we conduct research on policy relevant issues to advise policymakers in the UK Government Department of Health and Social Care and in the National Health Service on appropriate provision for people living with dementia and carers. So that's a wonderful opportunity to bring some of these important issues to a policy audience. So I'm going to finish there. I would just like to direct you to our website where you can find all of our scientific publications, which are downloadable, each one with an accessible summary. You can also find links to the resources I've mentioned, and especially the Ideal Toolkit, but also all of the others as well. And so I do recommend that if you're interested in these up, that you have a look. And it just remains for me to say thank you for listening. And I hope that this talk has inspired you to think about new innovative ways of improving quality of life for people living with dementia and their families. Thanks very much. I will stop screen sharing.
Linda, we would like to thank you.
Hopefully you can now see me again.
Can you hear me? We would like to thank you very much, because there are so many data and products, and I think it's a new vision for us and what's possible to do with dementia. We have some questions, but first I would like to, we have some problems with the subtitles. So I ask you if I can summarize your lecture just a little bit in Portuguese for people to understand better. Ok. Então, pessoal, ela apresentou o que seria necessário para as pessoas com demência terem uma boa qualidade de vida. E como a diversidade e as diferenças sociais, elas afetam a qualidade de vida dessas pessoas. Então, é um estudo, o Ideal Study, ele é um estudo de 10 anos, com 1.749 pessoas, em 34 centros, sendo que 1.460 pessoas participaram durante 7 anos e foram avaliados anualmente, inclusive durante a Covid. Desse estudo, 42% eram mulheres com vários tipos de demência, como doença de Alzheimer vascular mista, e foram incluídos cuidadores, na maior parte, mulheres e cônjuges. Eles partiram da evidência de que uma boa qualidade de vida está ligada não apenas à sintomatologia e à doença em si, mas a boas relações, ao engajamento social e a boa funcionalidade. Então, dessa maneira, uma qualidade de vida menor ou mais pobre, ela estaria mais relacionada a menos saúde física e mental e menos bem-estar do cuidador. O Living Well, ele acaba sendo uma visão que é bem mais ampla e que vai além dos sintomas, porque implica também na condição física, em funções físicas, saúde física, em atividades que a pessoa com demência ela participa, a participação social, fatores ambientais e pessoais. O Living Well, ele é um construto, na realidade, que é fruto da relação entre qualidade de vida, bem-estar pessoal e satisfação com a vida. E eles usaram escalas específicas para avaliar esses construtos, assim como fizeram entrevistas também com algumas pessoas. Então, em termos do Living Well para a pessoa com demência, o que seria importante? As características psicológicas e a saúde, a situação social, a saúde física, recursos sociais e manejo das atividades de vida diária. Então, nesse sentido, o bem-estar psicológico é o aspecto mais importante no Living Well, seguido da situação social. O que eles observaram é que, ao longo do tempo, a qualidade de vida masculina ela seria um pouco menor pelas dificuldades em lidar com várias dimensões. Observaram também que a qualidade de vida ela diminui com a depressão, a baixa autoestima e sentimentos de não ser a mesma pessoa, além da solidão. Isso tudo é o ponto de vista das pessoas com demência. Ela mostrou um folder, onde esses resultados eles transformam em aspectos práticos. Então, grupos, por exemplo, voltados aí para dificuldades de tecnologia, montaram folders, montaram atividades para ajudar as pessoas com demência no sentido de poder minorar isso. Outros grupos já foram ajudar em termos de atividades de rotina, como pegar um trem da maneira correta. Ela falou também, né, de arte e demência, do desenvolvimento de uma ópera como uma forma de inclusão e uma forma também de expressão das dificuldades, né, e do que significa ter demência. Para os cuidadores, as variáveis são as mesmas que irão afetar o seu living well do que aquelas vistas nas pessoas com demência, né? Ou seja, a depressão da pessoa com demência, o isolamento, a solidão e a qualidade do relacionamento. Agora, o que ela está alertando e que é muito importante é que todos esses fatores que são encontrados em estudos científicos, eles devem se transformar em perguntas que devem ser feitas pelos profissionais de saúde às pessoas com demência e os seus cuidadores. E aí ela, por exemplo, ela coloca várias dimensões, uma delas, né, as relações sociais, onde existe uma pergunta, você sabe quanto você gostaria? Ou seja, esses dados todos, eles só servem para que eles, na prática, eles possam ser investigados e eles possam ser utilizados no bem-estar da pessoa com demência. Em termos das desigualdades sociais, o que eles observaram é que ter desigualdade social, viver sozinho, são aspectos que diminuem, né, o living well. Na amostra dela, 18% da amostra vivia sozinha, a maioria eram mulheres com 80 anos, e embora essas pessoas elas fossem mais ativas e usassem mais recursos tecnológicos, mas elas também eram mais solitárias e tinham uma maior prevalência de depressão, o que ia implicar numa menor saúde psicológica e, sendo assim, num menor living well. O living well já foi avaliado em outras comunidades, como, por exemplo, em asiáticos e negros, e é importante entender, né, na comunidade, tanto dessas pessoas quanto de imigrantes, como é que os fatores específicos dessas comunidades afetam o living well. Em relação aos fatores de desigualdade que influem, os principais são a renda, a casa própria, né, o uso da internet e a idade e a educação, né, lá na Inglaterra, por último, né, lembrando que aqui no Brasil seria um pouco diferente. Eles desenvolveram vários produtos, né, a partir desses estudos, como o Living with Dementia Toolkit, para pacientes e cuidadores, que foi desenvolvido através de fóruns com os pacientes, cuidadores e profissionais. E nesse toolkit existem várias áreas, né, que têm como objetivo melhorar a vida da pessoa com demência. E desenvolveram também uma música, que é o Brave New World, como uma mensagem de esperança aí em termos dos cuidados na demência. Linda, thank you very much for your patience, and I will pass the questions for you now.
Thank you for summarizing the talk.
The first question is from Adriana Bisi, and she asks, is there any work in clinics to promote, guide, and inform about signs of dementia so that treatment can begin as soon as possible?
Could you just say that again? I have trouble hearing you a bit.
Okay, is there any work in clinics to promote, guide, and inform about signs of dementia so that treatment can begin as soon as possible? I think she's asking about some guidelines to early detection.
Early detection, yeah. Well, the short answer is there is a lot of interest in this area and a lot of work. It wasn't the subject of our study, so I can't really comment directly. But I know that there is, a lot of interest in this area, and of course now we are starting to see emphasis on blood biomarkers and on scans that detect amyloid before any clinical symptoms are evident. Of course, this is going to be high cost, not available very much in most countries, I guess. So, I think the emphasis currently is going towards physical markers rather than behavioral or psychological ones. But I think everyone agrees the importance of detecting dementia as early as possible, so that, obviously we need to have treatments to offer at that. And there's going to be important that we have not only medical treatments, but also psychosocial treatments that can be effective, like rehabilitative methods and so on, that can help people to have the right strategies to continue managing as best they can and engage in meaningful activities as well. Sorry, I don't know if I've really answered the question. But,
yeah, I think so.
I should say, Marcia, just now, that if I haven't answered the question, or if people do have questions that we haven't been able to address, they're very welcome to email me, and I'll do my best to answer, if that would help.
Don't worry, it's well answered. And it's the same we have here, the preoccupation and the need to develop early detection. And another question is from Nathalie de Souza. She's a PhD student of mine. And she asks, is there any studies that demonstrate the influence of poor decision-making capacity and its relationship with living well?
Yeah, that's an interesting question. And we did look at decision-making involvement, actually, not capacity specifically, but at how people were involved in decision-making. So we do have a paper on that, which I can direct you to. Let me just trying to find it now. So let's see. Where are we? Now I'm starting to look for something that's hard to find.
No problem.
Here we go. Let's try again. It is. We have got definitely a paper on decision making. I'm just struggling to find it right now. Let me see. Okay, I will have to come back to you on that. We have looked at it, and in general, finding that people do. We looked at how carers involve people in decision making, and how this is helpful for people, and it's in the ideal cohort. But there is also work on capacity for decision making. I think one of the main people working in that area is Professor Pizer in Australia, and we haven't gone into a great deal of detail on that topic, but it's certainly an important topic. And if you want to contact me, I can put together some more information about that, but I can't say very much about it right now.
Ok, no problem. Ela disse que ela não consegue responder isso agora porque o dado não está disponível rapidamente. We have been studying here a decision-making capacity, and we found that decision-making is linked has a relationship with awareness and with quality of life. It's an important relationship.
Yeah. I think that's really important, and it's certainly something I know we've talked about before as being an interesting area to look at. Our paper, I found it now, was looking more at what predicts in people's involvement in decision making about their own in their everyday lives.
We have another questions, and first the next one is from Duda Braga, and should like to congratulate your study and the researcher. It's a complete study that involves different aspects of the dementia and its effects, and that's really important to improve the work in mental health. So she's congratulating you. The other one is Antonio Sergio. I'd like to ask Linda how she thinks the challenge of developing and implementing more individualized approach for assessing quality of life in people with dementia could be overcome to better capture what is most meaningful to each individual living with dementia.
Oh, that's a really nice question. And well, I don't know if you know this, but we have been trying to look at this in Ideal, and I started thinking about it because I remembered in my early training learning about approaches in counselling psychology where people going to counselling would be asked to make a list of the things they were concerned about or that were problems to them or they wanted to work on, and then they would simply rate on a simple scale, say a 0 to 10 scale, how they were doing, and rate that every session and see how they were progressing. And then I kind of got thinking that something in a way that simple might be an adjunct to the standard measures, so that we could look at what was important for each person and whether that was happening in their lives or not. So I see it really as a sort of sort of extra dimension to assessment. And it's something we've been trying to develop, and right at the end of the talk I mentioned My Life Today resource, which was intended to do exactly that, to get people thinking about what is it that is important for them on their day-to-day basis. So, I was kind of thinking, I started thinking, if I had to go into a care home, what would I want them to know? For example, I need a really good, strong cup of coffee in the morning, and that would be really important to my quality of life. For example, the little things in life that are so important. I like, so you could list a few things, and that would start to give you a guide as to what is going to help for that person. And it might be that they can't necessarily do the thing that they used to do. If they like gardening and growing flowers, they might not be able to do that, but it might be really important that you bring flowers, or that they have flowers in the room, or something like that would be an adaptation. So I think with our questionnaire, My Life questionnaire, it covers those domains quite nicely, but what it doesn't, but only in a very broad way. So you would want to look in more detail in each domain of life. What is it for that person that's important? And so that's what we're trying to do with that resource. So it's still a work in progress at the moment, and we'll see where it goes. And I might come back to it and think about it some more, because I really wanted to do something for the care home context, and think about how individual preferences could be more prioritized, and so that carers would know what was important to one person. One, for example, actually from one of our people with dementia who was involved, who said, when I was diagnosed, and they were talking to me about what was available, they told me I could go to a singing group. But I don't like singing. I like art. I wanted to go to an art group, but there wasn't an art group. I had to go to singing or nothing. So we need to, we really need to kind of get a bit better at thinking about choices and how we can accommodate preferences. Not everyone has the same desires.
Yes.
That's for
and it's the need to give voice to the person with dementia. Yeah. To give them,
especially when it's hard for them to tell you themselves.
Yes.
So.
Yeah, that's it. And another question is how the diagnosis is communicated to the person with dementia. Is there a protocol to follow?
Well, I think the practice is very variable. We actually did a systematic review on this recently, and it has changed over time in the UK. There is now much more likelihood that people will be told the diagnosis. How it's communicated, we develop some recommendations. Sometimes it's done quite insensitively, but we hope on the whole it's done in a sensitive way. I think the bigger problem, I mean, it's always a shock when you get a diagnosis of dementia or a similar kind of condition. It's never going to be easy, and it's not easy either for the professionals giving the diagnosis. It's not good news either, so they need training and support to do it. So that's the first thing. But one thing I think is really important is it's not really a one-off. It's not something you just do and send people away. You really have to make sure there's some follow-up, because that first shock will dissipate a bit, and then people want the information. They don't necessarily want it right there and then, but they will have questions afterwards. And it's a kind of process over time. That's how I would see it. We did actually with Jen Yates, former PhD student of mine, we did a systematic review. So if you would like to email me, I can send you that if that would be of interest. Yeah. Just looking at what's good practice. Yeah.
It's a challenging aspect in dementia. Very challenging. We have a lot of more questions, but we don't have time, and I can send you after.
If you send me the questions, I can do my best to put down some answers.
Don't worry. And Professor Marcelo would like to talk to. He has some comments also.
Well, I'd like to thank again Professor Linda, in the name of the director of Institute of Psychiatry. I also would like to have a comment. Many of the aspects that are increasing the problems with like dementia are problems that we are all involved. There are problems that are problems of the whole world. Like we are an increase of the number of persons living more with more age. So because of that, more dementia cases. We have more solitude. In Brazil, the Latin cultures used to have bigger families. The families, traditionally, the Latin families used to be bigger. Like my grandfather had 10 brothers and sisters. But now there has been a change of modification, and now in Brazil the families are also small, like in Europe and or United States. Most of the families just have 1 or 2 children. So this is another kind of challenge, because there's less people to take care of the olders. And also we have an increase in the complexity of life, like Professor Linda has shown us, by challenges like the internet or dealing with the banks and the money. And we have modifications in the urban reality. In Brazil, the metropolis, most of them we don't have gardens. We don't have places where people, children and the others can be and stay, and that's another challenge. My question, Professor Linda, is that to be very interesting as a way of enhancing the collaboration between our institutions, to be to look at the cultural difference and the cultural aspects that are involved in well-being intervention. As you said, you had studies about different cultures because there's a lot of immigrants in the United Kingdom. We don't have so many immigrants here, but we have peculiar cultural aspects. So I think it would be very important to increase the discussion, collaboration between institutions, because we have, I guess we can have good results in this collaboration. Thank you very much.
Thank you. Yeah, I would be very delighted if we can collaborate further on those cultural issues, as you say, would be a great way to do it. And by the way, I don't know if you recognize the picture behind me, but it is the cathedral in Brasilia. Yeah. Which I was lucky enough to visit many years ago.
Oh, nice.
When I was going to go for a conference. So perhaps that's a good sign for collaboration. Yeah. I just realized it occurred to me when I was talking on.
Linda, thank you very much for your kindness and your time to present this fantastic lecture for us. And we hope we have an opportunity to meet again and maybe think about some collaboration. And you are very, very kind and very, very special. And Professor Marcelo now is announced our next study center for next week.
Oh.
Yeah. Marcia, can you read? I don't remember the name of the
I can read. Next week we'll have a congress, the good